Our hearts work and work without rest, but sometimes problems arise that need medical intervention. The trouble with our amazing hearts, tonight, on Call with the Prairie Doc. Good evening and welcome to On Call with the Prairie Doc. Dr. Holm is off today. I'm Kelly Evans, an internist with the Avera Brookings Medical Group. Our hearts beat about 100,000 times each day. They are amazing. It is a wonder that more things don't go wrong with them. Tonight we will look at some of those problems and the new treatments we have in our arsenal to help. First, let's take a look at this week's Prairie Doc quiz question. The most common cause of valvular heart disease in the developed world is A, narrowing of the aortic valve, B, mitral valve insufficiency, C, aortic insufficiency, or D, narrowing of the mitral valve. We will give the answer at the end of the show. Joining us in the studio tonight is cardiologist Dr. Michael Hibbard and cardiovascular and thoracic surgeon Dr. Molly McAfee. Both practice at North Central Heart in Sioux Falls. Molly, explain to us just what a thoracic surgeon does.
Well, a thoracic surgeon does surgery in the chest. So in the broadest terms, that includes the heart and the lungs, the esophagus, and then an area called the mediastinum, which is everything in between the two lungs and the heart.
Great. And Michael, what interested you in becoming a cardiologist?
Well, I grew up on the farm, on a dairy farm in Minnesota, and so I never would have, in my wildest dreams, ever felt that I would end up to be a cardiologist at the end of the day. But my mother was a nurse in the ICU at the local hospital, and one of my high school jobs, in addition to the farming job, was to run around with the ambulance service, and whenever I dropped anybody off with the ambulance crew at the hospital, the surgeon would take me under his wing because he knew my mother and took me into the operating room, and it was fascinating, absolutely fascinating. And once I was bit by that bug, the rest was history.
Wonderful. Well, let's start by talking about one of the more common diseases that affect our viewers, and probably one thing that they might be concerned about: coronary artery disease and heart attacks. What are some common signs and symptoms of heart attacks or coronary disease in general, and who typically gets these things?
Basically, everyone is going to get it, all right? A lot of people come up to me and they see me on the street and they say, "Geez, doc, do you think I got any artery trouble?" And I look them in the eye and I say, "If you don't look like you did in the high school yearbook, you probably have something wrong with your arteries." The issue is you got to take care of it every day because your life depends on it going, and you think of any other machinery that lasts 100 years, 24/7, 100,000 times a day, pumping 2,000 gallons of blood through 60,000 miles of pipe. It's an absolute miracle that we live to be 100 years old.
Sounds impressive when you say it like that.
It is impressive. It's phenomenal. I have two kids that are engineers, and they keep trying to figure out how they're smarter than their dad. And I just tell them to go to MIT, build me a machine that does exactly that, and then they walk up and leave the room, and then I can still sit on the throne for a few more minutes. The Hollywood has done us a disservice, I think, in terms of showing and illustrating what they think people have when they have a heart attack. They show somebody clutching their chest and sweaty and ashen and gray. That happens about 5% of the time. A truck driver at the truck stop can tell you that's a heart attack. The devil's in the details, and so many people just get aches in their wrists, their jaw hurts. I've seen people that have been to the dentist thinking that they had a cardiac or a tooth problem, and it turned out to be cardiac at the end of the day. Women don't always report things the same as men. People with diabetes and nerve disease that don't feel everything like an ordinary person. So you really have to realize that everyone is at risk. In the United States, 1 out of 3 women will die of vascular death statistically, 47% chance of a heart attack or stroke for a man. So when you realize that everyone is at risk, then you have to conduct yourself to think, how can I treasure this gift I was given when I was born?
So if everyone's at risk, what can we do to prevent things like heart attacks?
I tell people that I went to medical school and training for 20 years and I have 30 years of experience, and at the end of the day, only 4 things I can do for you. 1, I can do nothing. 2, I can try to get you to live healthy in the first place. If you don't do anything except get to your ideal body weight like high school and you exercise like your life depends on it, you reduce your heart risk 80%. There's nothing that I can do as a specialist with balloons and stents and bypasses and all the surgery that we have that gives you that benefit. But we don't treat our heart like it's a gift of life that everybody has. We eat too much, we don't exercise, we get plenty of stress, and if you think of any equipment that you want to last 100 years, you don't want any stress on it.
Mm-hmm. Wonderful. How about smoking? Smoking, good for the heart? Bad for the heart?
I can't believe anybody in this day and age can consider that smoking has any value. And my heart goes out to people that have smoked, because there's a disease called Berger's disease, which is a vascular disease that people can get where they're basically allergic to smoking. And I've seen people that were so addicted that they had their fingers amputated, their toes amputated, both legs. In fact, I had a patient that I took care of at a VA hospital who had lost both arms and both legs to the disease, and they had put an asbestos plate on his chest so he could still smoke with a little clip that he had for smoking the cigarettes. And he couldn't shave because he didn't have any arms or legs. And so the ashes would drip off of the cigarette and made a hole in his beard, so he had 2 wings on his beard. Exactly. So the addiction can be severe. Absolutely severe.
And I've seen a number of patients who it really was a major heart attack that caused them to finally stop smoking, though they may have known that they ought to for years.
Yeah, and I think most people, and the thing is that this is what I notice, is that most people nowadays realize that they should stop. It's just the devil to quit. They know it's wrong. They tell you right to your face that they shouldn't be doing it. They know that it costs too much, and they've seen people that have had cancer or heart attacks or strokes, and they still have a hard time stopping.
So when folks do get coronary artery disease or have a heart attack, we hear this term angiogram or catheterization. What exactly is that? How does that procedure work, and how is it helpful?
Well, what we do originally, actually, Mason Sohn started doing catheterization through the arm. In fact, Werner Forsman did the first one in about 1930, where he took a urology catheter and put it in his own arm. And it was such a radical concept in those days that he was actually removed from the residency and kicked out of medical school. He did the first catheterization. So nowadays, up until about 5 or 10 years ago, most people had their angiogram through their leg. I would say 95 or so, or 8% of the time now we do it through your wrist. And it's much less invasive. We still got to put the catheters in, but we go through a very tiny hole in your wrist. You don't have to lay flat afterwards. Mind you, we don't look at that as the first thing to go with, but if you do have symptoms, it's a relatively clever way to get in and get pictures and figure out what your options are to try to put the best spin on a bad deal.
And so sometimes people get what are called stents. Can you talk about that? And then on the converse, some folks have bad enough artery disease that we still do bypass surgery. How do we choose who gets what?
Well, that's what the 20 years of training was for, is to determine that. You really have to sit down with your physician and look eyeball to eyeball with all of your information. Nowadays, with all of the digital equipment that we have a great deal more information to make those decisions than we used to. The average person on the street likes the stent idea because you go in one day and you're out the next day. In fact, some people go home the same day. And as things have developed, we've become less and less invasive. I would say we do 60% more procedures outpatient that we used to be admitting people to the hospital for, just because it's so slick to go through a little hole, get your work done, and then get out. And plus, everything we use is so much smaller, which is why we can go in the wrist now when we never used to be able to. So for some people, stenting is the right thing. For some people, surgery is the right thing. But the whole goal is to avoid those invasive procedures if you absolutely can.
Dr. McAfee, can you talk to our listeners about what is bypass surgery in a nutshell?
Yes, I can. First of all, let me just say that Dr. Hibbard and I collaborate all the time. We talk about cases together, and that's one of the great things about being a heart surgeon is you get to work with just really talented people, and you get to learn what they can and cannot do. So just this morning, we looked at a patient together, and the question is it possible and is it safe to put a stent in this patient? And I look at every patient that I see, and I try to think, can we avoid surgery? Because I know that it's, it's very traumatic for people. But on the other hand, Dr. Hibbard took a look at this patient with me, and we decided the best thing for that patient, both in the short term and the long term, would be surgery. Mm-hmm. And so how do you decide that? You look at your own experience, and then there's just tons of data out there about newer stents, newer procedures, even newer surgical procedures. And so everyone has their own expertise and their own experience, and so we are very collaborative at the Heart Hospital, and it's one of the things I really like about it, to decide with the patient, yes, you have options, but here's what we think and here's why. And we want to make sure each patient understands that and makes that decision with us, because they're put in a position of having to trust people they've never met before. A lot of our patients, it's the first time they knew anything was wrong with their heart, and then all of a sudden they're faced with these really life-changing decisions. Mm-hmm. So it's really important for us to do the best for our patients. Mm-hmm. So as far as how surgery is done, we use the patient's own tissues, where a stent is an artificial cage or kind of a scaffolding, mm-hmm. if you'd use that term. Mm-hmm. With surgery, we don't address the blockage itself. Mm-hmm. We make a bridge or a bypass mm-hmm. over the blockage, and we use the patient's own arteries and veins to do that. Mm-hmm. And that procedure is true open surgery. It involves a huge team of people and keeps you in the hospital typically 4 to 5 days, sometimes even longer. Mm-hmm. So that's the nutshell.
Yeah, thank you. Mm-hmm. I think that rolls well into our case here. It's important to pay attention to our bodies and notice when something is happening that is out of the ordinary.
I went to a 4-H shooting sports morning, early January of 2014, and I had the classic kind of chest compression, and just didn't feel that well. So I stopped by the clinic, and the attending person at the clinic said, "Bob, I think we ought to have you be checked out from the hospital." And I said, "Okay, I'll drive from the hospital, the clinic to the hospital." "Oh, no, you won't. You need to have someone take you." I found that I had some elevated enzymes. So the next thing I knew, I was traveling in a Brookings Health System ambulance down to Avera Heart, and had emergency procedure to put stents in my heart, blocked arteries. I had 2 different stent operations in 2014, in January and then again in September. They were able to open that totally occluded artery, which made me joyful. I started taking more meds. I take some heart meds, but I have felt great, and in some ways it has had almost minimal impact on my life. For a while I ignored classic signs, and I would say that if someone else thinks they have these signs, pay attention to the signs. In my case, I had to acknowledge that I was getting older and there was some heart history in my family. So here was a chance to follow through on knowledge that I had. I'm glad I did. 2014 and 2015 were challenging years for our family, for me, but along comes Dr. Holm and the study, and I tell him my story, and he says, "You need this." After having gone through the first set of lessons, I totally agree. I do need this, and I am committed long-term to apply the lessons of balance and exercise and strengthening, appropriate diet, and a regimen that is heart healthy. And I think these things working together are all part of God's timing to help me live a life that's full and meet the needs of my family and friends.
Dr. McAfee, tell us how thoracic surgery has changed over the last decade or two.
Well, thoracic surgery, when I was in my training, had to do with making big incisions, opening the patient up, what a lot of people would traditionally think about when they think of surgery. And in the past 10, 15 years, it's evolved thanks to technology. And one thing that we have adopted is the same video technology that's used in abdominal surgery, for example, to remove a gallbladder. Now that's done through tiny incisions using a video camera, and the patients go home the same day or the next day. So, for example, if we were operating on the lung now, I look at every case as a minimally invasive case. And in the abdomen, that's called laparoscopy, but in the chest, we call it thoracoscopy. So those are just the technical terms, but it just means we're using video and we're seeing an image on a screen. We're not looking into the patient. Mm-hmm. So if I could show
Yeah, we have some pictures. Show us some of the common things that you do and what you mean by thoracoscopic surgery.
So the video camera is put through a tiny incision, usually lower down in the chest so it stays out of the way, and it gives you a picture, and I'll show later some real pictures of what it looks like. And then the instruments are put in through either side, and in traditional thoracoscopy, you stand at the patient's bedside and your assistant stands across from you. Here, just for comparison, is a typical thoracotomy where you make an incision and you open the skin, the muscles, the ribs, and often break the ribs in the process.
You know, Dr. McAfee, it looks like there's actually, do they oftentimes remove part of a rib to be able to get access? Because it looks like a pretty wide hole compared to how wide most people's ribs are open.
That's correct, and there are surgeons who would remove a rib or a section of rib or not, and I'm not sure there's any real advantage either way, but that is part of the procedure, at least in the past. But with the newer techniques, we don't spread or break any ribs, and I'm going to start with the simpler types of procedures. I see patients sometimes who have excessive sweating. The medical term is hyperhidrosis, but to the patient, they come in and they say, I have sweaty hands. My hands drip onto my page when I'm writing, they drip on my computer screen, and it's really kind of a random thing. It doesn't tend to run in families, and what we can do is we can use a video camera and make small incisions, either 1 or 2 incisions. Sometimes I just make 1 incision right under the armpit so it's completely hidden later on, and we put a video camera in, and then we cut this nerve. This is the sympathetic nerve that runs inside the chest. It's along the back of the ribs, and you can cut this sympathetic nerve and relieve sweating of the hands and the underarms, and it's instantaneous. In fact, we put a temperature probe on the patient's hands when they're having the surgery. Usually we're doing both sides, and as soon as we cut the nerve, the temperature changes in the hand and the hands are immediately dry. So it's a very popular operation if you have this problem.
Does it have any other effects when you cut that nerve?
No, amazingly it doesn't. You would think it would affect blood pressure and heart rate because you think about what the sympathetic system does, but obviously there must be other nerves that kind of take over that function. So we haven't found any short-term or long-term side effects. The only problem for the patients is that they still tend to perspire more than most people do. So they may just find, for instance, they sweat more on other parts of their body. But most people are very happy not to have wet hands. And another procedure that I really got interested in is repair of chest wall deformities. This is a congenital problem where the ribs and the sternum are, where they're connected together, those connections are abnormally flexible or stretchy. And a lot of these young people are very tall and thin and have very flexible joints. Sometimes they even have heart problems, if you've heard of
Marfan syndrome.
Exactly. Like a Marfan's, but there's also other kids who just have this variant and none of the other problems. And this used to be, we would make a big incision like this, cut away all these ribs, these cartilages, and then put a metal plate underneath and bring the sternum up. And it was a very invasive procedure until Dr. Nuss came along. And he thought of treating this more like fixing your teeth, that you just want to move them back into the right place. You want to move everything back to where it's supposed to be without doing anything too destructive. So we do this by, here's a patient on the operating table. We're looking inside the chest with a video camera, visualizing this bar, and we pass the bar under the sternum, and then we flip it over, and the sternum is elevated. This is what it looks like on an X-ray, and that's what it looks like in a real patient. So the bars are under the skin here, and sometimes we put 2 bars in. We leave these bars in for 2 to 3 years. Typically, I operate on teenagers and young adults, 13 to even up to age 30. And Mayo Clinic has shown that even adults can get good repairs, although adults don't have the growth potential. So the ideal time is in the mid-teens when they're having the growth spurt. And if you leave this bar in while the teenager's growing, then you can take the bars out after a couple of years, and they tend to get a really good result from that.
And do patients usually, do we know that patients have this pectus deformity when they're much younger, or when does this usually present?
It typically presents around the time the child's going to school, although it's highly variable, and I'm sure you've seen patients in your practice who just have mild. I see a lot of real mild pectus. It's the severe pectus where there are a lot of cardiac and sometimes pulmonary abnormalities because of the way the bone is pushing on the heart and not allowing the heart to function properly.
Okay. And so what symptoms do those young people have as opposed to the more mild pectus patient?
They get out of breath. I've had a lot of kids who are in sports, and a lot of, how kids like to be really active, marching band, all kinds of sports, they notice that they get winded much sooner. And we have a new test called cardiac MRI, which has been really helpful in showing that it's actually, we used to think it was the lungs that were abnormal, but it's the heart. It can't fill properly to keep up with activities. So they're fine at rest, but when they try to go out and do things, the heart can't function properly.
You can imagine the way that defect is with bringing your backbone much closer to your sternum. And so the heart is about the size of a grapefruit. It has to fit in there somewhere, and if it gets pushed to the side or sort of smashed to keep from being able to fill and augment the cardiac output when there's a requirement for demand, if you're being more active at a sport or in band, that and that can have just the fact of having the defect. Some kids make fun of you, or there's something different about you, and so it's a body image issue as well.
That too, and that's why we do the surgery with the video guidance, because you can imagine the tricky part of that surgery is getting the bar between the sternum and the heart and not injuring the heart. So we're watching the whole time as we're passing the bar underneath, and it's very satisfying because there's a lot of happy patients.
And we have a video from a surgery that you did, Dr. McAfee, I understand. So why don't we watch this video of real thoracoscopic surgery and tell us what we're seeing here and what this surgery was for.
This is one of the most common operations that thoracic surgeons do. This is a lobectomy, or a resection of a part of the lung, and this patient had lung cancer. And the instruments you see are robotically controlled. So it's thoracoscopy, but it's robotic. So it's a very expensive video camera and very expensive instruments. And there's a lymph node being removed. It's being peeled right off of the pulmonary artery. In that picture, the aorta is off to the right. That's the largest blood vessel in the human body. And the lung is being pushed over to the left side. And what's really cool about the robot is you have an extra arm. You see how there's 3 instruments in the chest? It's like you have 3 hands instead of, so you can use one hand to retract or hold something and your other 2 hands to work. And it has cautery, and the instruments move the same way your own wrists and hands move. Unlike most surgical instruments, which are just straight spears, basically they're just straight scissors, straight graspers. These move in just like your wrists move. So,
and this is a surgery that you're doing for cancer in this case. Why else might you do a lobectomy or removal of a part of the lung?
Occasionally for infection. But I would say 90+% of our lung resections are for malignancies. Now, when we say lung cancer, of course, we're talking about the most common cause of cancer death in men and women. And I think a lot of women are not aware that they are at risk for lung cancer. What's interesting is that we're seeing more lung cancers even in people who never smoked. I'm going back to this issue of smoking as a cause of cardiovascular disease and also of lung disease, but anybody can get lung cancer, which is kind of frightening. But the advantage of using the robot is I can do the same operation without opening up the chest and get the patient back to their recovery in half the time of a traditional thoracotomy. It's really changed my practice.
Interesting.
Yeah.
Do you think we're seeing some of these lung cancers in non-smokers more because of a declining rate in smoking, or they were always there and we didn't appreciate it?
That has been discussed a lot. Nobody really understands it, but secondhand smoke is a known cause of lung cancer. Radon, which comes out of the ground, is a cause of lung cancer. But these, about 20% of our patients now are never smokers who get lung cancer. And they tend to be more often women for some reason, and a little bit younger.
You know, one of the things that I think is really misunderstood about, I mean, the robot is impressive and the less invasive is impressive, but you have to remember that these people that are needing this surgery have smoked, and so their lungs aren't normal to begin with. So it's not like you're not doing surgery on people with normal lungs. So if you take somebody with emphysema and asthma
And heart disease.
and then make a gaping hole in them to do conventional, traditional surgery, it's very stressful. It increases the risk of cardiac complications, infection, wound healing, and then just having the other lung take over for the part that you remove or other parts of the lung. So having this non-invasive thoracoscopic surgery through these peoples minimizes damage, improves recovery for people that are in sort of a weakened or disadvantaged, situation at the beginning. And the other thing is that these techniques are very new, so only a very few people are formally trained on how to do this type of work in people with all of these other problems. And we're lucky to have somebody like Dr. McAfee who has that training and brought that to our health system.
And I understand it was you did the first robotic lung resection in the Dakotas this year?
I believe that is true, yep. So that's been really exciting. Robotic surgery is of course really taking off for urology, prostate especially, and for hysterectomies, for colon surgery. I understand it's really catching on a lot, where about 10 years ago when it first came out, the video wasn't great, the instruments were a little not so good, and now they're on the third generation. It just keeps getting better and better. The video quality is like when you got that first HD TV.
I'm old enough to remember when we went from black and white to color.
That's right.
Or from the radio to TV.
It's so sharp. It's unbelievable. And and it's also magnified. So as you saw in the video, the surgery is practically bloodless. Not all the time, but you have that opportunity at least to not make mistakes because you can see so well. And it's counterintuitive. You would think you need to be scrubbed in and looking into the patient to have control and to see well, but actually you get a beautiful panoramic view of the entire chest like you've never seen it before. So it's been very exciting to learn how to do that.
It's wonderful. Let's change gears and talk about valvular heart disease now. Now, the heart has 4 different valves, all of which can serve different functions, but what are some common symptoms of valvular heart disease that sort of might prompt your primary care doctor to go looking for those valve problems?
Well, the common thing, and this happens all the time, is people are generally told that they have a heart murmur. And the thing is what I tell people, and for some people they think that's very disturbing to have their physician tell them that. But I tell people that everybody has a heart murmur if they listen hard enough, because blood is flowing through your body and you can hear the water running in your house. It doesn't mean you have clogged pipes. It just means that there's flow, and it's good to have flow going through your heart. Now, what I tell people about murmurs then is there's 2 types. Murmurs you need to worry about and murmurs you don't need to worry about. And then distinguishing which ones you need to worry about are where the devil's in the details. Now, the symptoms of valve disease are usually fairly nondescript. Shortage of breath, probably the most common one. The thing to remember is that your heart beats 100,000 times a day, like I said at the beginning of the show, and you can imagine if you clapped your hands 100,000 times a day, what they would look like in 10 years. The heart goes for 100. So some of these valves have normal wear and tear. We see a little leakage, a little minor sclerosis, a little scuffing up and calluses. That's not the things that we worry about, because that's like getting gray hair and wrinkles. What we worry about is when things have gone too far down one direction. And there's two main problems. One is too narrow or too leaky. And for the narrowed valve, the heart has to do a lot more work to get the blood through these areas of narrowing, and over time that takes its toll. And for a valve that leaks, the concept that I use is in the old cistern days, we used to have to pump water for the cistern to get the water in the bucket to wash dishes. Well, if the seals aren't tight in that well case and the water wants to run back down the well, then you've got to go like that to get the water up. And that's exactly what happens to your heart. And if you can imagine that cycling over and over 100,000 times a day, it can wear things out. And if you wait too long to do surgery or to be evaluated, permanent damage can take place with your heart muscle. Fortunately, nowadays we have ultrasound, and it's a very safe, commonly used, widely available technique. And it's easy to do, so if the doctor's concerned by something that he heard during your physical exam, it's a readily available test to be able to see, is there something to worry about or not? And it's easy to follow with serial exams.
An ultrasound of the heart, also known as echocardiogram or echo for our viewers. And when do we do surgery, and is that a major event if we have bad enough valvular disease?
It's a major event. It's some of the biggest surgery that we do because we're working, it's like working on your motorcycle while you're riding it. It's, you know, the heart's beating and you have to be able to fix it or do it in a short enough time frame. Now the nice thing is we've adopted several of the techniques that she was talking about, that we're able to put valves in now through an artery without having to make the big major thoracotomy. And in the not distant future, there's going to be valves, prosthetic valves, to be able to put in for the other three valves. The most common one is the aortic valve. It's the main valve that lets the blood out through the heart. That's the most common one being worked on now, but we're in the process of doing it for the mitral valve, the tricuspid valve, and the pulmonary valve. And we've done all of those various valves except for the mitral, I guess, and the tricuspid percutaneously, but those are coming.
Yeah, and folks out there may have heard of this procedure, the common one being TAVR, T-A-V-R, or transcutaneous aortic valve replacement, as opposed to the open aortic valve replacement that we sort of think of. Very good.
Now, so there's a somewhat of a misconception, and I should make this clear, is that not everyone, don't call up your doc and say, geez, they're talking about doing a major surgery on me, I want to get the percutaneous one. There, just as we were saying with thoracic surgery, there are, and the nice thing, and I really like what Dr. McAfee was talking about with this collaborative approach, because you really need to have the specialty of cardiology, surgery, and intervention, and have those all in the confines of one place, so you can pick everybody's brain to make sure you're making the right decision. Because there's pros and cons, and the same set of circumstance may change what we would do depending on how old you are and how many other medical problems you have with the exact same angiogram or the exact same valve trouble.
And it's also evolving, just like the robotic technology. Each new valve that comes along is a little bit better, a little bit easier to put in, a little bit, you know, fewer complications. So I think the technology is amazing. How far it's come just in a couple of years.
It's very much a moving platform, and we were just talking this morning as we were going over this case she was mentioning earlier, that the things that we did in residency, no, I mean, I'm way back from when we discovered fire. Now the things that we do are just dramatically better. And even, you know, you pretty much have to go to meetings all the time just to keep up on the state of the art.
Yeah. And you mentioned certainly when you were in residency or training for thoracic surgery, you weren't using a robot. So how do you learn that totally new skill when you're a practicing surgeon?
When I started out in surgery, there was a robot sitting out in the hall and of the ORs, and people used to hang their coats on it, and so another guy and I decided to just start, you know, practicing. And what you do is you learn on either cadavers, which are human specimens, or animals. There's pig labs and all kinds of things, and the company has been really supportive in helping train surgeons, and also there's online training, and then of course you go to meetings. There's so much on the internet now. Anybody can learn to do surgery. So it's, but yeah, it's a process of deciding, does this work for me? Where does this fit into my practice? It's because so many things, as you know, come along and they're sort of fads, and you can get a feeling if something is really a game changer. And I think about the first few robotic lung resections that I did, the nurses the next day asked me if I had really done surgery on the patient. Wow. They said, that's not how this is supposed to look.
But I think it is good to keep in mind that in medicine, sometimes there's a little bit of marketing and they want you to go. And I know for a while there, if you did it with a laser, it was like you were state of the art.
That's a great example.
Yeah, the laser was, and I remember when we first started doing laser in my training when I was at Mayo Clinic, we had this great big thing. It was the size of a refrigerator and it cost like $2 million. and we brought it in and we tried using it a couple of times and we thought, this is never gonna be a boon for this type of vascular disease. And I still remember that we used to use it to hold the door open to the cath lab because we'd only use it like 8 times a year. And then we'd all be nervous because there were problems and this could happen and that could happen. And I still think of that as a $2 million, doorstop. And
I had the same experience with lasers as well, with lung surgery. It was going to be the next great thing, and it just wasn't.
So you really have to, as these new things come out, you really have to separate the wheat from the chaff and be aware so you don't get caught up in medical marketing so I would really encourage people to talk with their physician to get their information. I mean, there's a lot of advertising on the internet and YouTube and videos, and get your, find a physician that you can look eyeball to eyeball with and feel like they're giving you their best information and go with that.
Yeah.
And we're not saying all lasers are bad.
Yeah. And I don't want the laser people to write me letters now and say, it's not all lasers are bad, but this just particular iteration of equipment turned out, it was a good idea, maybe had some concepts behind it, but it just didn't pan out. And you're always having to vet these things to see, is it really
we're going to get letters.
That's a common
that was
laser.
Dr. McAfee.
In medicine in general is that, a lot of new technology and new thoughts come out, and it sounds great, but we just never know until you do the science, you do the randomized controlled trial, which we love as physicians if you can, but it takes years to really figure out what works and what doesn't, and so that's why we all train like we do and take all that time to learn so we can pass that knowledge on. We have a few minutes left. Why don't we touch one more common topic in cardiology, and that's atrial fibrillation. Can you tell us basically what is atrial fibrillation? We probably have a lot of viewers who have atrial fibrillation or have a family member who has it, and how do we treat it typically?
Well, there's an epidemic of atrial fibrillation, and almost everybody knows somebody that has it. And the heart was designed to go in a nice regular rhythm, top chamber in coordination with the bottom chamber. People that, if you live to be old enough, 1 out of 5 people are going to get atrial fibrillation. Almost everybody is going to have exposure to it one way or the other. And what happens in atrial fibrillation is the top chamber is deranged, the electrical system gets out of whack, and then the bottom chamber hits and fires whenever and is irregular. And it can cause a lot of problems. The most common one, almost everybody's seen those commercials on at night. If you have atrial fibrillation, think about taking these blood thinner medications so you'd end up with a stroke, which is a terrifying thing for most people. We have a lot of different treatments for some people now to just simply be put on blood thinner and control the heart rate is the best strategy. For some people, we need to try to get them into a regular rhythm. And for some people, they can't be put in a regular rhythm, they can't take blood thinner, and now we have a new percutaneous gizmo that we can put in called a Watchman device that can go into the area that causes a lot of the blood clots and be placed, and then you don't have to take the blood thinner. Now, it's not for everybody, so all the people people that are taking blood thinner are totally fine now. Don't go down and say, I want to get one of these devices put in, because it's always better to manage things non-invasively if you can do it. But so there are a lot of treatments. One of the common people that most people would recognize is George Herbert Walker Bush had atrial fibrillation. So if you have it, it's not that it's the end of the world, and you can still be president of the country if you want to be someday and still have atrial fibrillation.
Our viewers might see a lot of commercials on TV for all these fancy blood thinners. What's the verdict on the new blood thinners versus the old standby warfarin?
Well, the old standby warfarin was actually developed by moldy alfalfa hay, and cattle started bleeding, and that's how we discovered the drug. And so that has been used for years. There's tons of experience with it, and if you're taking Coumadin, it's not a bad drug. It's just that there's many things that can influence how thin your blood is. It's affected by diet, antibiotics, liver function, and so they came up with these new medicines that you don't have to go every month and have your blood thinning level checked. The problem is these newer drugs, anything that's new in medicine usually costs more, which is one of the liabilities. And two is only one of these new ones has an antidote. So if you come in and you need emergency gallbladder surgery, or you need appendix out, or you need a tooth fixed, they stop it and it wears off and you can have the surgery. But there's not really an emergency antidote except for the one, and that emergency antidote is like a $3,000
And not all
medicine.
hospitals carry it.
And not
'cause it's
all
so
hospitals have it.
expensive.
So there's a variety of issues. You just want to make sure that when your doctor is going through the best therapy for you, that they think about all of these pros and cons, and to make sure that it's the right thing for you.
Excellent. Very good. Well, let's go back to our answer for tonight's Prairie Doc quiz question. The most common cause of valvular heart disease in the developed world is A, narrowing of the aortic valve, B, mitral valve insufficiency, C, aortic insufficiency, or D, narrowing of the mitral valve. And the answer is A, aortic narrowing or stenosis. We'll be right back after this.
All around town, from stores to playgrounds, babies are on the move. And there are diseases that are on the move too. And some of these spread easily. To best protect him from 14 serious diseases by the time he turns 2 years old, vaccinate him according to the recommended schedule, so he can go on about his business and you can have peace of mind. For more reasons to vaccinate, talk to your child's doctor or go to cdc.gov/vaccines.
When should one worry that he or she might be having a heart problem? Unfortunately, heart symptoms can be all over the board, and sometimes there are no indications for trouble until very late in the game. On top of this, perfect and classic heart symptoms can be due to just esophageal spasm or musculoskeletal strain and not heart disease at all. That said, there are clues for heart trouble that could help us know when to seek help. Taking into consideration the age, gender, size, lifestyle, and situation of the individual in question definitely helps, because in general, there is a higher incidence of heart problems in people with a smoking history, positive family history, increasing age, and male gender. But heart problems can occur in anyone, so never cover up or ignore symptoms, especially knowing that heart disease in some people, especially diabetics and women, can present with very unusual or minimal symptoms. Hypertensive and overweight snorers should have an inexpensive nighttime oxygen test to see if a full sleep study is needed. Sleep apnea is a dangerous and important cardiac risk factor, and I believe way more worthy of attention than cholesterol. If suspicious, talk to your doctor, since discovering sleep apnea could add years to your life. A middle-aged or older person having a heavy sensation in the chest, neck, jaw, shoulder, or arm that comes with exertion, is relieved with rest, sounds suspicious for a blockage of coronary arteries. Called angina pectoris, this alone may not be dangerous unless it comes on with progressively less exercise. Still, angina means see your doctor. And if these symptoms come on suddenly, severely, and don't go away with rest, then you have a very urgent problem. Call 911. Heart weakness, also called congestive heart failure or CHF, can be caused by heart disease that's involving the valves, long-standing high blood pressure, chronic alcohol use, certain viral infections, and more. The most common symptom from CHF is shortness of breath, but almost every illness, especially lung disease, can cause shortness of breath too. Heart rhythm problems are sneaky, and many of us, including me, have benign sporadic palpitations that are not dangerous and mean nothing, but worthy of discussing with your care provider. Runs of heart rate in the 150 range, or rates so fast or slow as to cause weakness or passing out, means you should go to the emergency room. As complex as all these warning signs may seem, the most important way to diagnose heart disease starts with paying attention to symptoms.
A big thank you to our guests tonight, Mike and Molly. Their experience brought great insight to our topic. We're in that time of year when we're all spending more time outside in the sunshine. Remember to put on that sunscreen. That does it for us tonight. From all of us here on Call with the Prairie Doc, until next time, stay well.
Can't get enough of the Prairie Doc? Then visit our webpage and other online programming. You'll find extended interviews with guests and more information on important medical subjects. Visit prairiedoc.org or follow us on Facebook. The best way to stay healthy out there.
Major funding for On Call with Prairie Doc has been provided by
Avera is a proud sponsor of On Call on South Dakota Public Broadcasting.
Larson Manufacturing is proud to support On Call Television as it continues to open doors for important medical information.
and by the South Dakota Foundation for Medical Care, the Medicare Quality Improvement Organization for South Dakota, and with the ongoing support of these individuals and institutions: Brookings Health System, Ophthalmology Limited, South Dakota State Medical Association, Avera Heart Hospital, Dakota Allergy and Asthma, Fishback Financial Corporation, Vance Thompson Vision, Aberdeen Asthma and Allergy, Black Hills Medical Society, Dakota Bank, Orthopedic Institute, Physicians Care Sanford Clinic Community Service Committee, Regional Health, Swiftel Communications.